to Muzzy now. Muzzy, the language. Checking records passed away this afternoon.
How's everybody?
Hello.
How you doing? To whom am I speaking?
Hello, I'm from Bulgaria.
Hey, what's your name?
Edwin Vasvi.
Oh, let me get myself off the spotlight. That's why I'm not seeing you. Okay. Yeah, nice to meet you. You were here last time, right?
Yeah.
Yeah, because I noticed Bulgaria, you say, right?
Yeah, Bulgaria.
Welcome.
Thank you.
We start in about 10 minutes, actually. I guess everyone's coming late. You want to meet you? And does anybody want to meet you, huh?
I don't know why you can't see me.
Yeah, I can see you. How you doing? Yeah. Edvin.
Yeah. Okay.
I'm John Bennett.
Hello, I'm a resident, still fifth year.
50th. Wow. How many more? That's it after this year, right? You finish?
Yeah, in my country, residency is 5 years.
Yeah, right. So you start working at a hospital next year.
Yeah, yeah.
Here's Juha now. You want to, hopefully you can talk to him. I'm sure maybe if you have any famous neurosurgeons in Bulgaria, he probably knows them.
Well, we have like Professor Gabrovsky, if you have heard of him, and Professor Marinov.
I myself am not a neurosurgeon. Hello, Juha, you there?
Okay, I'm here. Okay.
How you doing?
Gabrovsky was in Helsinki sometime years
Oh,
ago.
okay. Oh, okay. So you heard us speaking, yeah. So you knew a Bulgarian neurosurgeon.
Yeah, Dr. Gabrovsky was sometime in Helsinki, and I have been in Bulgaria one time, I think, lecture.
Okay.
Well, you are welcome, sir, to come again. We would like to see you. And
When the world opens, takes long time.
we will be very happy.
Yeah, but takes long time. I don't see any date you could travel now. Europe is in flames, America, North and South are in flames, so travel restrictions will be long time.
Yeah, there is a new lockdown.
Well, you say in China, it's working pretty good. They're very, very strict, right, Juha?
Yeah. There are some 7-8 cases in the whole China daily, but extremely strong, strict control all the time.
Oh, okay. You can't leave your apartment, or what kind of restrictions are there?
I'm working
Oh,
normally, but when you go to hospital, there's a heavy checking by the guards, and then cellular checking, and you have to wear masks, and this belongs to this is the name of the game.
Outside the hospital, your travel is restricted?
Yeah, it is controlled. For foreigners, it's controlled, so you have to plan very well, and
Okay.
You have to show that you have not been in areas where there has been COVID.
Oh, okay.
I wanted to go to Shanghai to visit Subin's hospital in December. They told, because there has been one case of COVID, I cannot come.
Oh, wow.
You understand? It's completely different game here.
Wow. Wow. It's not like that here. It's very lax, very lax. There's no enforcement of anything, really. They may have the law or the restriction, but it's like optional to obey it.
Yeah, it is heavy control.
I'm communicating with Dinko. I hope he can come today. I tried to say come today in a panel.
Join that he sees, yeah. It would be very nice. He has must have been very lonely because he has not joined the webinar. So long year in isolation.
Yeah. Well, no, he answered the email. So.
Yeah, but so emails are different than the webinars.
Yeah. So you've been busy? You've been operating a lot?
Not so much. Hugo has been extremely busy. They are doing bypasses every day, and many bypasses every day, because the Moya disease is very common here. So even 3-4 bypasses a day.
Wow. See. Okay, Z is going to help you set it up, right? Or Ben's going to basically run it, right?
Yeah, lacking bin. Subin, we are lacking now.
Okay, he hasn't come quite yet.
We need him because he has the lecture.
Yep, yep.
Hello, Juha.
Hello,
Hello.
Hiratoshi. Nice to meet
Nice
you.
to
Hello.
meet you. Hello.
Great to see you. You seem to be very good condition. Wonderful to see
Yes,
you.
yes. I'm doing everything. Yeah, I heard. You're still doing the bypass? Many bypass, you said.
I'm not doing bypasses, but they are very common operations here, 500-600 a year in this hospital because of the heavy load of moya disease here in the Henan. So my co-worker is involved in them. Uganrad is involved.
I see. Yeah.
Good opportunity to get experience of a lot of bypasses.
Yes. Yeah. I'm just doing the still aneurysm surgery and AV malformation only.
Yeah. We are
But
the old
no
school
time.
direct surgery.
No time to go to the foreign country because of Corona.
Yeah, this is so restricted now. So it is. I have not been traveling 1 year, and I suspect it will take 1 year more for free traveling. So.
Yeah, you are contributing for the many countries and India and the Bangladesh and now China. Very amazing.
The webinars are a good way to teach. You don't have to travel anywhere.
No,
just give your lecture and then you are home.
Lecture in the home, but in Japan, inside of the Japan, I am doing to the many area, but not outside of Japan. Only inside of Japan. Yeah, last week Kyushu and usually Tokyo area and Nagoya area. Yeah.
So you are still extremely active now.
Yes,
you are still active. Very active.
Yes, thank you. Yes,
good.
Yes.
Good life. Good life.
Yeah,
I'm happy for you.
Yes.
Yeah.
Same as you.
Yeah. And your wife is also good condition.
Yeah, good condition.
Your wife is also happy with your heavy working.
Yeah. Yes. But she herself is doing the tennis and golf and that. Yes. Yeah. But yes. But by myself is the walking, and sometimes I playing tennis.
Yeah, it's great to continue.
Yes.
You seem to be in very good condition, and so you are very active,
very good
skillful neurosurgeon. So it is great that you can continue.
Yes.
Subin is here.
Yeah, he's here.
Subin is here.
He's the key man.
I just arrived home.
How you doing?
Hi, fine.
You're the main man.
Sorry.
Right, no problem.
I have eight moya and 1 AVF immunization today. I just finished.
Wow.
Okay.
We started 2 minutes. Okay.
I will give a short introduction, like in earlier Yasergil webinars. No then we go. Subin will write a lecture on the AVMs. So My
Okay.
introduction takes maximally 2-3 minutes.
Okay. I think Warlick's is coming. She'll introduce you.
It is soon 8 o'clock.
It's 1 minute. Warlick's always waits till the last minute.
Yes, it's a very busy
Yeah,
person.
she'll come. She'll come. I guarantee she'll be here before a minute. Okay, well. Okay.
Okay, we go. We begin.
Yeah, okay. Let me introduce you first. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach, home of Neurosurgical TV. We have the pleasure today of hosting Juha's China Neurosurgery Grand Rounds. And let me just turn it over immediately to Juha. Welcome, Juha.
Thank you, John. So we have as our honored guest, third time, Professor Yasergil, and I will quickly introduce him. Of course, if somebody doesn't know the name of Yasergil, then he's not really involved in neurosurgery. So I just repeat the main things which I have experienced. So Professor Gazi Yasergil was born in Turkey in 1925, so he is now 95 years old. He is the greatest neurosurgeon of all the times. And I saw him first time to operate on 1982. It was like a miracle. I studied medical science in Zurich, but then later as a young neurosurgeon, I went back to Zurich to see Professor Yasergil to operate on. And during these times, I remember extremely well. The first case was ruptured ACAM aneurysm. It was a beautiful operation. He was handling the aneurysm like without any fears, skillfully coagulating down the aneurysm and clipping. And the same happened with the ruptured basilar bifurcation aneurysm that ruptured during the operation. He calmly coagulated down the aneurysm and then clipped. About the AVMs, what I saw remained in my mind. One large corpus callosum AVM, skillfully taken out, coagulating all the feeding arteries and then slowly taking the AVM out. And then one very special case was a posterior fossa AVM. In angios, it was totally black. It was extremely highly vascular, and he could take it out because he had strong will. Besides skills, he was never giving up, and this was the extremely important learning for me. Professor Yasergil has developed since 1967 everything for modern microneurosurgery. When I was first time to learn from Professor Yasergil, 1982, then the first Chinese neurosurgeons were there to learn. 1982, we were many young neurosurgeons around the world, and because you couldn't speak anything in the operation room, not even cough, so we went after the beautiful operations to discuss Then afterwards in a restaurant, this is Weiser Wind restaurant downtown in Zurich, and we discussed the beautiful operations of Professor Yasergil. Operations were like miracle. He was like Usain Bolt or Muhammad Ali, #1, and then nothing on the second place, and then some neurosurgeons at the third place. So when I became chairman in Helsinki, 97, so I saw the possibility to invite Professor Yasergil to operate on in our clinics and lecture in our clinics. And he came first time 2001. Here is a drawing from 2003 by my first Chinese fellow, Hu Shen from Shenyang, now in Shenzhen. Professor Yasergil and Mrs. Yasergil operating on, I'm assisting there. I opened and closed for him. And then in this drawing is special that all the people here look Chinese, and this is how you see the world from different perspectives. And this is Professor Yasergil in Helsinki. He continued the 3 summers, and then we continued the life courses in Helsinki, became very popular and famous. And during my time as a chairman, more than 3,000 people visited Helsinki. So this is from Helsinki 2013, life course, dinner. What is important here, you see the main students of Professor Yasergil in the back row, Christ in Little Rock, and Ugur Türe in Istanbul. Reza Dasti was my fellow, now in New York. Mika Niemela is my successor, and in the middle is Evandro Oliveira and me. And this other picture is from Istanbul World Congress 2018. Professor Yasergil was there and is still active, writing books and articles. So we have to give credit to our teachers, and now we see the lecture of Professor Yasergil. So I finish here. Thank you very much. Join us to see the greatest neurosurgeon of all the times.
Okay, we're going to turn it over to Ben, right?
I close here.
It looks good. Perfect. We have no
Can
volume.
you hear it?
No, we
No
can't.
volume?
No volume. You may have to start again.
Okay.
Yeah, just start again and turn the volume on before.
And then
Is it okay?
Perfect.
Little-
Perfect.
Okay, okay.
Then in some areas, as a visiting invited neurosurgeon, some few in other countries. The vascular organ, it is an organ. The differentiation between arteries, capillaries, and veins, the interpretation of systemic cardiopulmonar and distinct central nervous system hemodynamics, clarification of the biology of the blood and the lymph organs, these are other organs, elucidation of vasomotoric system and of the enigmatic blood pressure, still is not well controlled, required centuries of intense investigation to achieve effective knowledge. The history of medicine presents us an impressive cooperative but also a controversial evolution of concepts and convictions related to the vascular organ and unique functions. The vascular system in general and the neurovascular system in particular disclose anatomic, embryonic, histologic, genetic, physiologic, pathologic, medical, and surgical fascinating aspects. For young colleagues, each area is still open to discover new aspects. The neurovascular organ evolves into phylogenetic, ontogenic, infantile, adult, and elder age stages, stepwise. And the transformation of the vascular system is unique. We will show this. It is a heteromorphic and heterofunctional open system with a unique capacity to fluctuate and adapt according to focal and regional requirements of blood supplement. The history is very important. I recommend all of young colleagues to go a little into the history, because the deeper we go and seriously study what's happening, then we have a much more view for the future. And then it took long time until in the 19th century was discovered, on the 20th century, a paper in Marketplace von Egyptisch medicine. It's between 17 to 25 centuries before. And then Brestedt bought these papers and then give to the museums, and later on it was deciphered. And you see here how in old Egypt written the name of brain and gyri, even membrane, and CSF. I didn't have a chance to study these things myself. I would see also the vessel, how they documented in hieroglyph. But there is an excellent paper from Professor Wilkins, American neurosurgeon, in Journal Neurosurgery, 1964. You can see page 240 and 244. He gives a short information, but very important. On the left side here we see a statue. There's a famous Imhotep. He was some 2,000 years before Hippocrates. He's a unique person as medicine man and statesman, and he is the founder of the Egyptian medicine. We have to relate to this because the Egyptian was the originating, and later on the Mesopotamia, and then finally in Greece. Now, in Egypt, these two Greek scientists, we can call them as a fathers of neuroanatomy and neuroanatomy also. Herophilos was born here in Istanbul and went to Egypt, to new built city Alexandria. We know from history Alexander the Great made a unique conquering to Near East, to Central Asia, and built some 10 cities, Alexander cities. And then in Egypt, he was very impressed from Egypt culture, and he built Alexandria. And these two gentlemen started to study their anatomy, and they had a chance to see also how the experts in Memphis nearby, how to prepare the mummies, yes. It's correct, and mummy, yeah. And interesting, they studied all the organs and saved all organs of body, but the brain was destroyed. Funny, they entered transnasal and destroyed. It's said. Now Herophilus studied the brain veins specially, so we have his name now in Torcula Herophili, where the superior sagittal sinus and the transverse sinus connect. And also the Erasistratus was an expert on vessels and also in the arteries and veins, and then sensoric and motoric nerves. They studied all this. They gave a first steps of the neuroanatomy. I don't like to stay longer here because I have to tell you more. Visiting Mexico, and I operated also there 2 cases, and in the hospital of pediatric hospital. In the entrance of the large hall, some 3 meters high or more, is a fresco on the wall showing entire history of the vascular organ and diagnosis and therapy. And all involved people are also Chinese and then old Indian and old Native Americans are presented. Very interesting picture. If you go to Mexico City, you can see there, and the Hippocrates is here, the Galen is also here, and all others. Interesting is Ibn al-Nafis. He was born in Damascus and was active in Cairo. He discovered the pulmonary blood circulation, coronary arteries, metabolism, and he described very well how the blood circulation lung in the bronchus happens. He wrote his books around 13th century, but it was translated in Latin and went to Venice and from there to Europe. And Servetus took this knowledge and put a small paragraph. The begin in the Western world, modern neuroanatomy is Vesalius. He is from Dutch and came to Italy, and in Bologna, Padua, Pisa, Venice, he was working. He died in age of 50, unfortunately, by a trip to Near East. But he made it excellent systematic studies, and he had an excellent artist to draw, but he made it. In 1543, he published his famous book in Basel. In Basel, there have been several experts for pictured books. And so we see first time here the brain well and all the brain arteries and veins. Vesalius was studying the Galen's anatomy, but was found it is He was stimulated, but he found some 200 wrong information. If we look to this picture of this vessel, arteries and veins, also there is some confusion is there. It is not precise. But he was a begin, and he stimulated. He's not alone. Around him, before and after him, then it started 100 or more anatomists. Important as far as the English scientist William Harvey went to Italy, and he learned in Bologna from Italian anatomists a little more about the vessel system, and he got the excellent concept how the blood and body circulate, and published 1628 his famous book. But some authors in Europe said this is nonsense, this is everything is wrong. This is normal, this is contradictory concepts. Thomas Willis is another great scientist and surgeon. He had a chance to dissect and study, and he gave an excellent book about the brain arterial, but also the brain cortex and the subcortical areas and the lentiform nuclei. He realized the special anatomy and gave an excellent picture about the circulus cerebri, the arteries at the base of the brain, how they connect. So it's called now circulus of Willis. The pictures was drawn by famous great English architect Wren. And same time period we have a contribution from Malpighi. He discovered the capillaries between arteries and veins. And then it is not well known, Wepfer is a Swiss scientist and practicing doctor. He wrote 1685 or 58, and in this some voluminous book in Latin, he described very well circle of Willis, but there is no picture. He discussed the stroke and very precisely the TIA, transient ischemic attacks, and the full stroke. These four gentlemen gave the basal column for us neurovascular system. A historical picture made from great English architect Wren, how it looks, how he saw the brain and the spinal basilar artery and the circle of Willis. And later on, this is now drawing by other artists, all in anatomically precisely. Next slide, please. Now, the interest was born, and we see in 17th century, Frederick Roche, another Dutch scientist, he found a technique to inject fluid wax into arteries and gave some colors. And it is unique. You can see in the middle picture, perfect, everything is there. How he made this, incredible. And he was giving lecture in the entire Europe, and the people have been excited. Also, we are excited. Look here, this is fantastic. And then another center is the 18th century, but in Italy it was an old tradition. the wealthy people did like to have a what if in church that made a from wax the figure in Zumbo. Zumbo is the leading man, and then the Suzuni. 100 years later, look here. If you are in Florence, visit the Museum La Specula. In 4 or 5 rooms, there are exhibited some 2,000 wax figures. They are made by wax. And you have the feeling, oh, they are living. So such a vital, animated figures. At that time, it was the only chance. There was no photography, no films and videos. This was a good teaching stuff, and he made it 2,000 entire body. I was very impressed to see also the spinal cord vascularization, so perfect, so incredible. And you see here, on the brain, you see all the arteries, there's a better brain. But somebody really, the TV system should go to Florence, make more pictures. And Suzini got helped by another scientist, neuroanatomist, Fontana. Fontana was well informed, and he made the section, and then he made the wax figures. In 2000 was given to the University of Vienna in Austria, then Montpellier in France, and one in New Orleans. The pieces in Vienna and Montpellier are still intact, also in Florence, but in New Orleans they disappeared. Another recommendation for you is this publication from Marin Padilla. I met him on a neurosurgical meeting and was impressed how he presented the embryology, ontology of the entire brain. And he showed us how the meningeal system and the brain tissue and the vessel synchronically developed. This, and I asked him, please give this a paper for us, a chapter. It is now in the volume 3A, Micro Neurosurgery, AVMs. You can read some 20 pages and excellent pictures. Then you are at home. I'm surprised by discussion or by papers. It's not well realized, this synchronical development of meningeal system, parenchymal system, and vascular system, and CSF system. Here, in these 2 books, 2 volumes, in the first one, I gave the anatomy. In second one, B is the surgical experiences. 414 cases at that time. First book, A, was published 1984, and the other one, 87. In the first book is Marin Padilla's embryology. And I would say it should be well discussed, and it was appreciated for some colleagues. They said, oh, they use the books if they operate the AVM. But I would like to present it again, discussion in other journals. This is also history. Now, if I am done, maybe they will start to study these things. There are really information. It is not my own idea alone, my work. I had around me in Zurich excellent neuroanatomists, and neurologists, and neuroradiologists, and then visiting colleagues, and discussing with them, and discussing where I visit also other countries, and so hundreds of colleagues discuss. It is our time period between 1953 to 2020. Who is this man? He is a great French general surgeon, Perrin. He operated in May 1889. First case, 15-year-old boy, had a left-sided Jackson epilepsy. And now Jackson, first time described, if somebody has only this type shaking of the extremities, one side, on the opposite side, maybe a tumor. And you may believe or not, in volume 3A, I put a list from 30 cases operated from general surgeon. They thought it is a tumor. It turned out to be AVM. And it's interesting. Some could remove the AVM or ligated some vessels, but he made a removal of the central area. And you should read his article and very in French, very important. Now, it is also in the pathology discussed. Great Austrian pathologist Rokitansky, in 1851 he published a 6-volume pathology, and he was expert in carcinoma of liver, and he believed there are tumors. And John Bell in England, he separated, differentiated some 6-7 type of vascular malformation. And then Virchow, 1851, gives credit to Bell also. He studied micro AVMs and said dilatation of small vessel, and the erected tumors was before said, but he said it is better to say them aneurysm arteriovenosum. So it's the term still present. We can differentiate also some 6-7 type of malformation. I like to mention also William Hunter, English gynecologist and general surgeon, and then he gave the term of abnormal anastomosis between arteries and veins, erectile tumors. So the term for anastomosis comes from Hunter. His brother John Hunter was also a genial person. He taught himself by his brother's laboratory, studied all animals, and he also found arterial collaterals, the term. He operated aneurysm of the popliteal, and he ligated the femoral arteries. So in Western literature or Western world, neurosurgical, it is well known is Hunter ligature. But I will tell you it was earlier. Now, the entire development was a great breakthrough by this German physicist, William Röntgen. 1895, he discovered He was behind it, but he, like Madame Curie, they carried the radioactive structures, elements in their pockets. He discovered 1895, and we see here the first AVM in Moniz Lima, Moniz and Lima publication. So it was great. Harvey Cushing, as a young neurosurgeon in Johns Hopkins Hospital, he insisted to have a X-ray operate. They bought, and it happened. A young lady was shot from behind with gun and was paralyzed. And he made a X-ray, Röntgen ray, and then there was a projectile in the cervical spine. He operated the lady and she improved. So Cushing, as a general surgeon, later he introduced legally the neurosurgery separated, and he introduced the radiology in the neurosurgery. He was the pioneer on this. But there are other pioneers. Oppenheim is a neurologist, but he supported the German neurosurgeon Krause very, very much. Then you have Professor Schiller in Vienna. He studied especially head bones, precisely wrote a nice book and describing all that in detail. He's one of the pioneers. He left in Australia, went to Australia. Walter Dundee in Johns Hopkins Hospital, another very great neurosurgeon in USA. He came to the idea because he saw one patient with an injury of the intestine. It was the air in the abdomen. He got immediately the idea, hey, we can use this for ventriculography. So he introduced cysternal air cysternography and ventriculography. Later on, Sicard in French used another material. And Lysholm in Sweden brought better X-ray apparatus. And in Portugal, Egamonis as neurologist and Dalima neurosurgeon, they worked together, and Moniz on a meeting in Paris saw angiography of the extremities. And he came to idea, we must do it cerebral angiography. And he started to use this for first in dogs. And then later he had a help by the Dalima, as a neurosurgeon. He made all the angiograms. And so it started 1930s, the cranial angiography. This is the history. Here, we know now a lot about the AVM because we have now the possibility to make the angiography and study in different phases. And they can be in dural, in skin, in muscle, bone, dura, and in cysternal area, and then pia, cortex, subcortex, and then deeper area in the ventricle and also in the orbita. It's a unique disease. It attacks usually one segment of the brain and spinal cord, but it can be so combined. They are very rare. We saw only 2 cases in Zurich. This type extended. These malformation can make a headache or seizure or mental deterioration slowly and or bleedings. But then if there is a bleeding, the people are alarmed to give an indication for surgery. But we have to pay attention. The perfusion of the blood flow in brain is a certain pressure. In the veins, this pressure goes down. But if we have a direct connection between arteries and veins, there is a high pressure in the vein. As a consequence, you see on this lower picture, the venous system may get stenotic, especially its straight sinus, because it is fixed in the dura. If we see the narrowing, we have to do something. Here you see a patient had a right side. We see from top. I like to see right. Here the first picture, right side, white color, as you know, the blood, and in the middle, amygdala, hippocampal area, mediobasal temporal, and AVM. And Mr. Roth, our artist, made a beautiful picture. I appreciate very much the work of the scientific artist, because on picture it can be excellent, even on MRI with 20, 30 modalities. They are two-dimensional. But the artists, they bring the vital condition, they animate it. We can see here almost how the blood flow go around. It is the knowledge of artist and his talent add something. But in MRI or the CT and all other pictures and the angiography is two-dimensional. I will talk this later. And in these cases, we can operate. We can remove the malformation and also the blood and the tissue which impregnated from blood, because brain doesn't like blood. It makes seizure. We have to remove, in these cases, was also seizure. He didn't have a bleeding. You see, I've mixed a little the picture, sorry. This was the angiography of this mediobasal temporal lesion. In the basilar vein and entering into the galenic is dilated, because straight sinus, you see, it is not full color. So it is a stenotic, and it is narrowed. Here, postoperative. Sorry, I put wrong. The postoperative is gone. It's intact now. Coming back, the AVMs, they can be localized in neopallial area, in archie, in paleopallial area, in the basal ganglia, in the diencephalon, mesencephalon, down. Here, this was combined by Valavanis. You can see different type, one in the frontal, superfrontal, in pyramidal shape, and here in the middle frontal area, and then here in the temporal area. In paleopallial, and we see here mesiobasal temporal, and here the cingulate area, and here the insular area. Historically, we have to give a great respect to Professor Herbert Oliver Krona in Stockholm, and he made excellent aneurysm and AVM surgery, tumor surgery, especially schwannoma surgery, and described very well. And here is how he removed the malformation in a circular approach. He published 1957 his experiences, and on a meeting I made myself this photography. Left side you see Professor Tönnies, chairman in Bonn, Germany, and Oliver Krona. He published, Tönnies published also 1959, his book. But pay attention. Oliver Krona saw 1923-35, in 12 years, 18 cases, operated 5. But 47 to 54, he operated from 64, 80%. This is advanced. You have to read the original result from Oliver Krona. Here is my teacher and chairman of neurosurgery in Zurich. He founded the neurosurgery in Zurich, 1936, was chairman until 73. Very strong character, very disciplined, but correct. And I assisted him in many surgeries. He operated altogether 188 AVMs. It published partially, but not completely. And I was planning to do it, but it remained still. He was an excellent surgeon. He operated mostly in the polar area, temporal, occipital, frontal, parietal areas. And he knows his own limits. He said, I can do it, or I cannot do it. This is very essential. And if he decided to do it, he took time, and he was patientful, very meticulous, and disciplined. I entered the neurosurgery in 1953, and next day I had to go to radiology. There was no radiologist until 1978. Valavanis came since 1978. And I had to perform transcutaneous carotid vertebral and orbital angiographies, and had a great number of patients because we didn't have a CT and MRI. Postoperative control, if there was some unclear situation, we made angiography. Or if the patient came in, first apart was the electroencephalography. If there was any clear sign left or right side, okay, we made the ipsilateral angiography. But sometimes it was not clear what's here. Papillary edema and the patient has seizures, okay. We didn't like to make a ventriculography, was made sometime, but angiography first. So we get a great number. And now, for the colleagues, the first blue books concerns the vertebral-basilar, more infratentorial, arterial, and venous system, all the variation is German. The second book is entire carotid and vertebral, and it is good. You should see these books because I spent really some 10 years to study from thousands of angiograms the variations, individual variation of each arteries. But I have to give a great respect to the publication of Newton on pot. I found they made a volume 4 in an excellent publication of angiographies. Newton spent for a while with us in Zurich, and so we get a good friend. Now, here in Zurich, we had a special dish apparatus. Dr. Kreinbill brought this from London, so by artists. You can put, we made a serial angiography with change position of the X-ray camera, 5 degree, and another series. On our series have been always 6. Beginning of the arterial phase, then full arterial phase, capillary, late capillary, and early venous, full venous, and the sinus. And we spend every afternoon 1 hour with Dr. Kreinbill and studied here. There are right and left, there are 2 serial picture, starting with the early arterial and later. And here in the middle you see double mirror, and you can open the axis a little related to your eye distances and move forwards, backwards. You can study frontal, central, and then parietal occipital areas beautifully. It is, you can have even on, they show now on television, houses, and then inside apartment, etc. But it is not 3-dimensional. If you have this 3-dimensional system, you have the feeling you are sitting in the brain. You are in the room. Then you got relation. Is not a foreign object. It is like your own body, the whole room. So this was our way, and I am very unhappy. This is also not generalized. Nobody used this technique, this stereo angiography and study. And I may say, I am still missing this 3-dimensional angiography, and we don't have any CT and MRI 3-dimensional. So I'm missing this. It is not same quality. Now, what is wrong? Our pupillary distance is in average 60 millimeter. And then by magnifying glasses, it is 40 millimeter. What you here see is behind the objective of the operating microscope. There are two small eyes. These are 16 millimeter apart. So it gives us the stereo view. Here's the trick. I may apologize. I forget to put this in a publication. I forget to put this picture. This is the essential part. Why we? And also, we are accustomed to see binocular or stereoscopic. If we are looking quietly, it is a stereo, three-dimensional. But if I move my eye, it started to be four-dimensional. If I move the body, it's much more four-dimensional. If somebody move in the room, it's almost five-dimensional. And so we live normal life always with 4, 5 dimensions. And then this modern world fix us in the books, in CT, in MRI, and on the TV, and on the video. And we made also videos, take the operations, three-dimensional. So you see on your backside the two boxes, they are projectors for the stereo pictures. I have some 3,000 videos in depot to show how to operate, and you can see three-dimensional. Okay. Now, also we have to have not only 2 forceps. There are some 30 forceps. It could be more, but also this is enough. Different tip size and length. We on surface, you see like here, and then longer. You go deeper and deeper and deeper, then you need longer. We have forceps 13 centimeter long, and this is very essential. And then, sorry, I must go back one here. And then I developed this, I asked, and they made it this hydraulic chair. I can move up and down, and we have nice wheels. And then armrest. Mobile armrest, hydraulic, turn 360 degree. So your arms are stable, forearms and hands. You can stay in the air 10 minutes, 15 minutes, but then you will have a unprecise movement. You have to stabilize the arm to be precise. This is my message. And it was not possible. In Zurich, a company did not make continued to make it better. And now in Istanbul, somebody in a company made it. It's available now. Another important stuff for surgery are these sponges. These are very special sponges in soft, different size. I may use really 100, 200 pieces in one surgery. And if I use, and the nurse give me a new one. Now, coming to the surgery of AVM. I learned also from publication from Oliver Corona on tennis and watching Dr. Cranville. We can eliminate the superficial arteries, they are dilated, and the deep arteries from the base, they are small. Now my main critic to the endovascular approach to the interventional neuroradiologist, if they eliminate all these cortical branches on surface, and then the blood flow is reduced. But if they are not eliminated, the feeder from perforator, there is a still arteriovenous connection, and they get dilated. And it is extremely difficult if these are occluded and some other here around, and you approach, and this is very difficult to coagulate them. Then we develop special small clips for this, temporary clips. Now, you see the AVM, pyramidal shape, segmental, from the superior frontal area onto after removal. And here on MRI, how it looks, pay attention, the carotid angiography, the straight sinus is stenotic. And all, they look so really impressive, large AVM. They are not that much large, they are dilated veins. They cannot flow. They don't have a good flow because there's a stenotic straight sinus. You can see almost in at least in 70% of AVMs are straight sinus stenotic. Here after removal. Here we didn't remove any normal tissue. We removed just the ill area. Another case, important. I showed these cases, you know why? Pay attention. I did know there is one large vein artery coming in. I removed this part. And then you see on this picture, on the upper corner, the pyramidal shaped AVM removed, but the deep perforator is still there. I didn't know this, but I didn't dare to enter in this area, not trouble the internal capsule area. So I told the family, sorry, there is a rest. But I know one colleague, he could help. And then I recommended to go to Zurich, and Professor Valavans will close this. It happened that I was also in Zurich. From Little Rock, I went there. It took not more than half an hour until he brought the catheter in and injected and gone. You see, it's clean. So the patient is in an excellent condition, but the combined work is very important. Here is another case. Young girl in the age of 15, 16 had a bleeding where in central sulcus. And she get a hemiplegic few hours, then improved normal condition. And I always tell to people, we have nowadays 3 possibilities: endovascular embolization and gamma knife radiation. And see if what you like it. And I have this experience and so I let free. They went to Stockholm to Dr. Steiner. And then Steiner's concept was correct. He said, what said Dr. Yasergil? Did he said he can operate? If he said this, you should let operate. So he is expert, he can do it. And then they discussed a little because such a long AVM needed 2-3 sessions. And the girl decided to come to be operated. 15, 16-year-old. And you see the lesion on surface, and then some 6-7 centimeter long, or the longer pyramidal shape, we cut it. And she was intact. It made a very good recovery. You can see on these pictures, MRI and the angiography, well made it. This is possible. I operated over 500 brain AVMs and some 80 spinal. I had some negative results I will show, but mostly we got it good. 2 gentlemen came from Germany, both medical doctors, and added right-sided, both right-side, parieto-occipital AVM. As you can see, on surface they look terrible. But then you have to imagine now with your knowledge in anatomy and then analysis of this 3-dimensional angiography, where you start and how to go. It's a difficult, demanding, challenging surgery, but it needs endurance and discipline. It can be done, as you can see here. He came out without visual field effects, also other doctors. Here. You see the angiograms is normal, right and left. Here, where is this? Is the mediobasal temple area, large lesion, and even no straight sinus, and after removal. Here another case, 1972, 73, we got a computer tomography. It shows right-sided in the posterior mediobasal temple area lesion. You can see this is parahippocampus going in direction parieto-occipital fissure. Young boy. And I said, we have to do this. It's that dangerous. You see, there's no straight sinus. But in these cases, we should operate interhemispheric parieto-occipital approach down to splenium corporis callosi, from there entering to the malformation. I told already, I operated some 58 cases, and I didn't have any case with visual field defect or hem syndrome, no hemiparesis. It is possible if you run well, but if you go transcerebral from lateral down into the lesion, this can be, you see here, I show you. From lateral, you destroy so many fiber system and cortex, etc. Correct this medial approach. The point is to get the concept. Here, another case, same area, and after removal, here is also very weak straight sinus. And you see here, he sent to me this ping-pong picture. He made a very good recovery. Another case, larger in the splenium area. You see here. if you look to the picture first moment, you get shocked. And you say, oh, this is impossible, this is very difficult, dangerous. But studying the picture, three-dimensional, and then you can do it. And you see here, well made it. He's a farmer. Or this case, a little more in the middle field of corpus callosum. Now the corpus callosum becomes from the pericallosal artery branches to the cingulate and to the corpus callosum. So an AVM may involve both. And this was well published in a paper of Dr. Ture, the vascularization of this area. You see here how it looks. And here. Here is the patient, and he sent to me the picture. He came from Holland, from Dutch, Netherlands. Another case. Here is involved corpus callosum, middle portion, and then the cingulate. Cingulate that is also 4 or 5 sectors. Here, it looks terrible. Also from vertebral, and this is postoperative. There's another case, more anterior. It's going down in the septal area after removal. This gentleman came from United States to Zurich. Another case. Here, more in the septal area, one anterior cingulate and corpus callosum. You see how the draining is troubled, straight sinus, and it tries to find collaterals. We have to have an excellent stereoscopic angiography, 4-vessel angiography, to understand the architecture of this malformation. And after removal, another case. Here, where is this? Now, the time is over. Before, as I started neurosurgery, we diagnosed topographically frontal, temporal, parietal, occipital, or down, We could 1950 some 20 topographic diagnoses. Nowadays, you would not believe me, but we have now, by modern MRI and angiography, super selective, 500 topographic diagnoses, precise. You can tell there's there. Where is this? If I show this, they say frontal. Yeah, which frontal? It is fronto-basal. Caudal fronto-orbital area. This here. And after removal, you can see better now. We saved everything. We didn't injure any tissue and vessel. And here, duplicity of the cases, right-sided. We could remove this also well, you see. And this was interesting. As you see, Professor Valavanis came with catheter down there, and then he called me, please, I fear to do anything. I don't like to inject. It's very complicated. You should operate, okay? And we operated this gentleman. You see, there are two parts. There is a one caudal frontal orbital, frontal area, and then a little more medial part, septal area. There, you see here, frontal orbital and septal area involved. You can see yet now better where it was in the middle picture. Down there you see how it could be well removed. Now, here I am coming to show you a lesion. Where is this? It's not the frontal parietal or frontal temple area. It is in the insula. So we had to make a precise diagnosis. Look here, also here, the trouble with the venous drainage after removal. Here, another posterior part of this is predilection site, posterior insula, retroinsular area. Here. And after removal. Another case. In the volume 4B, I presented this in the detail. Here, look here, another lesion in insula, but straight sinus is stenotic. And after removal, where is this lesion? Where is this lesion? This is a young lady, secreted by a practicing medical doctor, had an acute severe headache and became right-sided hemiplegic and aphasic. But interestingly, she improved within short time and started to speak. She came to Natural Hospital, and the MRI showed the bleeding in the putamen pallidum area, and the angiography showed a complex lesion in the lentiform nucleus, putamen pallidum, and having also feeders from all lenticular straight arteries, not from leptomeningeal, only perforators, but also from Heubner group. And I discussed with her and her mother. Her father was in military service, and she said, I offered, we will discuss this now with the gamma knife or embolization, but both have been a little skeptic. They said, we need several sessions, and embolization very difficult, small arteries. It was interesting. The patient was very clear. She said, doctor, I trust you, you will do it. Try it. If I should die, I die in your hands. This is shocking. But we had to wait until father came. He had the permission, etc. It took 2-3 weeks. Then finally we operated her. It was a long-lasting surgery, several hours. But you see here, clean. Also the lesion there in putamen pallidum area, this was the AVM. It's gone. And now she's a happy lady, she get married, has now children, and she's working in the neurosurgical department as secretary. These are this are great moments for a surgeon to see such a good result, enjoy with the family, and encourage to do also some more. Then we became a young boy in age from 12, I think so, I forget now. Where is this lesion? In the center of the brain. And even stenotic situation in the straight sinus, it is in thalamus. Now, thalamus has also several sectors. I forget to mention, brain and spinal cord, all together, they have at least 1,000 septal area, segments. We can differentiate and see, and this is now in the posterior part of the thalamus. And we operated. He made a good recovery, but here happened something. I came parietal interhemispheric approach and then removed the lesion, and it was excellent, and the boy enjoyed. But next day he started to sleep, and the mother gave alarm, said, he's changed. And then we made a CT, MRI. There was an acute hydrocephalus in the temporal horn, because in operated area, the cella media came down and get fixed. And this can happen. And we explored and made free the area. There was no AVM. And I didn't do anything more, just cleaned. And he recovered excellently. And he later became a captain of a transatlantic ship. So he's doing very well. You see, the brain is intact. These are experiences. This is another boy. He was a son of a military person in Austria, USA military person. As you see, he has also a complex situation with transverse sinuses in trouble, and both sides, transverse sigmoid sinus, are in trouble. The lesion, it looks great, not so big, in the thalamic area. It's so-called vena-galenic AVM. And we discussed the situation and said, we have to do something. And we made it. You see carotid vertebral angiography. And this clip was unnecessary. And I never used any clip by AVM surgery. We coagulate. Here, you see there are 6 types. In the book you have to study this. They are just arteriovenous connections, but we have cases with plexiform lesion also in thalamus and in mesencephalon. This is a medical student, came to us to Zurich from Italy. Huge varix. The lesion is not so, but pay attention how large is the venous transmesencephalic veins going through. And we had to be very careful because we put small temporary clips, but still was still bleeding. So it was an enormous fighting. And we succeeded. As you can see, we made it. And she made an excellent recovery. And she got a dentist. Just, I operated some 80 cases of this cerebellar AVM. They came in each area, there are segments. This is a midline, superior part. As you get, oh, this was wrong. This is now a lateral lesion. Again, trouble in the straight sinus. And after removal, I saw two disc types, cerebellopontine AVM. And it was very difficult, but in this case, I could manage it. This is the cerebellopontine AVM through foramen Luschke entered in. And after removal, and here the vertebral angiography. Recovered very well. Here is another case, large lesion in midline, removed well. And this girl here had a only symptom, torticollis, with this lesion. You would think this is impossible, the entire hemisphere is involved. And then straight sinus in trouble, and she developed new collateral venous system. And this is after removal. At that time I used clip. This was before CT time, it's 1968, 69. She made a very good recovery. Now, a table for colleagues, this is in the book in details. In 3B, I gave precise information how much problems may arise on what we made it by. 414 cases, 81, I don't like to say the word excellent. Even myself, I don't feel, never myself excellent. Good is good. So the good condition is no neurological mental deficit and working. And this was 81. And then some problems, some seizures by 13%. In poor condition, we have a 3%, but we have some 2.5% mortality. And mainly the problem arises by 16 cases, 16 cases galenic AVM. I learned if there are plexal AVM, we should not operate because it's in the mesencephalon and in the thalamus area and the encephalon. Maybe young generation, maybe Dr. Ture will go in this field. I lost from 16.5, and you will read in the book the stories. I still suffer about these cases. In spinal cord, look here, large lesion in the vessel, and they look terrible. And I saw only aneurysm arising by spinal AVMs. And I operated some 80 cases, small and large. And it can be well removed. And we published together with Lindsay Simon, he died also, and in volume 11, Advanced and Technological Standards. I tell these colleagues they may find us more information about. They are not so difficult. They look so very difficult, but we can be dissected. That's it. Professor Krisht, this is what I prepared for this lecture, but I would recommend to study volume 3A and B. This is not my work alone. This is our generation work. And I wish I am now 95, and I hope some few years more to prepare the AVM cases from Little Rock on Zurich, or somebody should be behind it. We will discuss this. Good luck of you and all colleagues in the United States. You should be courageous to operate, but you have to prepare yourself in the neuroanatomy, vascular anatomy, and have a good support in neuroradiologists. And very important is to have excellent team in operating room. And these are the operating nurses, and they must be neurosurgical operating scrub nurses. And I don't accept the concept a nurse should be everywhere able. Cardiac surgery, they are expert, but the brain is much important region. And then very important is excellent neuroanesthesiology. They have now better medication and more fantastic control, all these parameters, but they have to stay with the patient. We surgeons, we stay. We don't leave to go to smoke or to have a coffee break. They have to stay 3, 4, 5 hours in the room and follow each details, and then it can happen every moment something wrong. So we have to have a good unit, and then good intensive care and the floor nurses. I have been very fortunate to have these conditions in Zurich and Little Rock. I hope if you are not well in your team, don't do it. This needs full operation and full team. I talk too much. Thank you very much.
Okay, very
Okay.
good. Okay, Warleth. Go ahead, Ben.
Okay. I already finished the translation.
Oh, okay.
Yeah.
Okay, Borlex, are you there?
Hey, thank you, everyone. There's like lots of panelists join us today, and I cannot accept more because they're like have already full in the plate. So I think it's time now for the question sessions. So we have Professor Juha and also Dr. Beans to are willing to answer the questions today. So if anyone's our panelists have a questions, you can ask directly, or you can even like type in the chat box for the questions. So it's open floor now.
So may I say comment?
Yeah,
Sure.
yeah.
It was tremendous to see what
Yes.
kind of cases Professor Yasergil, as a pioneer of microneurosurgery, has done. Everyone who is doing microneurosurgery in AVM should read carefully the volumes 3A and 3B. They are also translated in Chinese, so the Chinese neurosurgeons should read them extremely careful. even when the endovascular treatment is now coming, so you should take a look. All the world is speaking about these cases, that they are inoperable, that if Professor Yasergil could do it 40, 50 years ago, that kind of tremendous cases, it means that he had the anatomical skills, microneurosurgical skills, and strong will to do them, besides the good team. So we should study these cases extremely carefully and not to say that these are inoperable cases. We cannot treat these patients. This is extremely important. If the pioneer could do it, so we should do even better with our present imaging and treatment methods. So study carefully these tremendous experience and difficult cases and beautiful results. So this is my comment.
Okay, Warlock, there is a comment in the chat box. Do you see it, Warlock?
Okay, thank you, Professor Juha, for the suggestions and comment. So there we got a questions from Dr. Jayun. He asked, sir, for the case that have ruptured grade 1 AVM with hematoma in premotor area, in which that's not causing mass effect. His question is, when to operate this case, immediately or after 4 to 6 weeks?
My practice has been not to wait. I have been always operating them immediately because psychologically it is the best moment to treat after, to do surgery after bleeding. If you wait, then you are facing an intact patient and then you are delaying the recovery. This has been my practice, not accepted all over the world. You are waiting, like in China, you are making EVD in difficult cases, then you make angio, partial embolization, then you wait several months, and then you do again embolization, and then I think this policy is making very long recovery period. If you attack the lesion immediately, then you could do difference. I want to hear what Subin is saying here.
What do you think, Ben? Did you catch that?
Yes.
Okay.
Actually, I'm translating for Professor Juha.
Okay.
Yes, I agree with you, Juha. For the grade 1 AVM, I will resect it immediately. But for some very large and very extensive AVM, maybe we can wait after the absorption of the hematoma.
Okay. Thank you. Okay, Warlocks, take over.
So yeah, so besides the questions, there's a lot of like thank you, sir, for great lecture. That was amazing, and a lot of people. So maybe people are trying to ask questions. Okay. So what's next?
Maybe there's not big discussion. We have to give credit and respect Professor Yasergil's lifetime work. He is our teacher. He created everything in microneurosurgery 50 years ago, and all the neurosurgeons in the world are his students. If somebody doesn't know his name, he's maybe not involved in neurosurgery or should not continue, because you have to know the history of the treatment, and then you can continue and get better than former generation. But looking at this lecture, it is really extremely difficult to do better than Professor Yasergil did in his times when he was a strong man to operate with strong will and skills in the surgical skills and knowing the anatomy.
Okay, do you want to wrap it up, Juha? Do you want to take more questions?
I think I have told what I think. Greatest respect. If somebody wants to add it, it's okay.
Okay. If anybody has any last minute questions, otherwise we'll wrap up.
John, can I say?
Yes, of course.
Professor Juha and all other panelists, I'm Dr. Harshad Parekh, once again here attending Professor Yasergil's lecture series. Amazing craftsmanship which does not match anyone. The whole, as his Professor Juha says, if you don't know Yasergil, you don't know the neurosurgery. You don't do it. And exactly is correctly said, his technique, his technology, and his will to operate and give these fantastic results, no one can match him. Yes, we should learn this. We should inspire ourselves to do this kind of work. I don't think any questions are required. It is his lifetime work, what he is presenting. Amazing, amazing. I was fortunate enough to see him operating live when he was very strong to operate and doing cases, 3 cases, 4 cases in a day. Amazing work, amazing, unbelievable, unbelievable. Thank you very much.
Thank you. Okay, you want to take us out, Warlicks? Hello, Warlicks?
Okay, so it's a really honor for us to have Professor Yasergil to give a talk today, especially very important topics such as cerebral AVM and spinal AVM, especially for the young neurosurgeons like me. That's really passionate. He's not only talk about his experience, but he also explained that how it's become and a lot of things and very beautiful like illustrations that maybe sometimes I have never seen it before. So I will move this to Professor Juha to wrap it up and end the sessions. Please, Professor Juha.
Thank you, Warlicks.
I think we have told already everything. Greatest respect to Professor Yasergil. So we remain in gratitude for him, for his strength, anatomical skills, microsurgical skills that he developed our area, and we have to follow him all the time and read his books. They are also in Chinese, translated by Ling Feng. So please read them. They are extremely good books and still actual nowadays. So I think it's difficult to say something new here, just great admiration to the greatest neurosurgeon of all the time. So we are lucky and happy to see him to present still. So we wish him good some years more to continue his work. Thank you very much.
Okay, we'll end it there. Okay, Warlicks.
Okay,
We'll
thank
wrap
you
it up.
everyone today. And waiting for another exciting topics and honor speakers who will surprise you. Okay, thank you very much. Thank you everyone today.
Thanks, everybody.
Thank you.
Thanks, sir.
Thank you, Supin, for translating, and thank you, John.
Thanks, Ben. Thanks, Juha.
Bye-bye.
Thank you, Professor Juha and Professor Bin.
Thank
John,
you, Harsh.
see you. Thank you.
Thank you, Ben. Thank you very much.
Thank you. Thank you.
Bye-bye. Bye-bye.
Bye. Bye.
Hey, it's Vlad.
Yeah, hello.
Hey, say hi to Juha.
I joined a little later. Juha, hi.
Oh, lad.
Hi.
Hi, Professor Lad.
Good to see you. And from what I've heard, it was an excellent lecture. Can I share with you my experience with Yasergil?
Yeah, sure.
Yeah. I've been in 88, 89 in BNI with Bob Spetzler. And that's the place where I have learned everything. Coming back, I went to Zurich for 2 weeks to observe Yasergil. And when I came home, I was just, little, not disappointed, but I thought, well, those were 2 weeks. I saw something, that's okay. But slowly on, I just realized that I'm using the forceps the same way he does. I'm using more and more the mechanisms and the techniques which Yasergil was doing. So these 2 weeks were at least as valuable as a year in BNI. Great place and great neurosurgeon.
There's someone sharing a extra CT, I think. Did you see that, Warlocks? I don't know if it was relevant.
Dr. Erkin, I guess. Maybe if you want to ask a question or something. I'm not sure.
And let me tell last thing about Yasergil. Juha, when I came to your place, you know, it was 8-9 years ago, and I saw you doing your surgeries. I had a déjà vu. It was exactly the same as Yasergil, down to the last minute point.
You are totally right. I was copying his techniques 1982 when I was there. So I was following every second what he was doing. And then I came back to Eastern Finland and began to follow his footsteps and read everything what he was done.
Yeah.
So my greatest achievement is that I could follow his surgeries. But when he's giving the lecture, he knows the anatomy by far better than we do. And I cannot follow, for example, the ideas about the archaeoneopallium, AVMs. This is very difficult to understand. I have read the books many times. I don't understand it. I don't catch it. So his knowledge on history and anatomy is so huge. So it is not possible for a regular person.
Perfectly right and honest. I don't understand it either. That's probably something in Yasergil's mind which we all others lack, which we do not have. He's really extraordinary in anatomy. Extraordinary.
I think he has read and studied so much without sleeping. So when I sent one of our young neurosurgeons to be trained by Valavan, and then Yasergil was in Helsinki, he gave a list what to read. It was 2,500 pages of neuroanatomy.
Right.
Of course, a regular person cannot do that.
Yeah. I've been standing with him in a library in Zurich. You remember the place, definitely. And the site was excellent because you saw the Alps. And I just told him, it's nice to be so close to the Alps. You are there within 20 minutes. And he was just watching the mountains. Then he turned to me and told me, never been there. He never been there.
He never went to Alps. Or once he went to Alps, and when being with him in Gran Canaria, so 2002, he was first time on the beach in his life.
Right. Right.
Yeah.
When I had him in Prague, we were in a hotel, you know, the Hotel Pyramida. It's like 10 minutes from the castle in Prague, you know, slow walk and you are in the best site in the whole city and in the world. And I just told him, let's walk for an hour. I'll take you to the castle. You will see beautiful things. And he told me, no, I have things to read.
Wonderful, wonderful. Amazing.
He's wonderful, extraordinary person.
Extraordinary.
Extraordinary.
I happened to be there in 1991. Amazing. His library and worth see.
Yeah.
Worth. He was all the time in hospital to see the patients.
All the time. And when he wanted to see something and you told him, I would like to see this or that AVM or aneurysm, he immediately told you the name of the patient, where you will find the video, everything.
Everything.
Extraordinary memory.
Even at 95, he remembers everything. Anatomy is superb.
Yeah.
Unbelievable. His library has got thousands of videos there, and he will say, pick up that video and see how you operate the thalamus, how you operate a thalamic tumor, how you operate a thalamic AVM. Amazing technology.
Yeah. In 1971, there was the European Congress in Prague. It was organized by my father. And there was a special session on a microscope in neurosurgery. And Yasergil was the chairman of this session. Guess how many people were there? European Congress. On this session, there were altogether 15 people attending.
Oh,
But the book was given from there.
Yeah, right.
A book
Right.
was given. First book on microsurgery was
That's
given
true.
there.
That's true. That's true.
great work.
Okay. Where is Goralux? She has wrapped already.
There.
No.
He's muted.
Yeah. So we have certainly many memories, everyone.
Yeah, do you want to meet these distinguished neurosurgeons? Anybody? You want to talk to them? They're very accessible.
I'm shy. Still like.
Go ahead, Gorlix.
Still I've let go my step. Today today it's an endovascular day, so only the diagnosis AVM too, but and the P common resistance. Small step. Very small step. Yeah. So we are still await for your surprise from Professor Juha, who will be our honored guest lecture next time. You always surprise.
Okay, so we try to get Vincodolens involved.
Yeah, I'm trying to get him. I'm trying to get him.
Yeah, trying heavily. He's a great man.
Well, I hope he
man.
saw this show. I gave him the address. I hope he saw it.
Okay, we hope that. We pray for that. I don't see his
Waiting
name
for to
here.
see.
No, but he may watch it. He can just watch it on Neurosurgical TV.
Okay, okay.
It was easy.
So we keep heavy pressure on him.
Yep, we do that.
I believe you can do that.
I'll get Warlocks on him.
Yes.
When she's hungry, she'll go after him.
I am just young neurosurgeons that the new generations that I have only read on the books and then those names and curious that who are they? Something like that. That's all. Oh my God, I'm so shy. Okay, I will read the book that you say, Professor Juha.
Okay, now it is rather late here in China, so thank you very much, John.
Okay, thank you
for nice.
Thank you, everybody. Thank you.
Thank you, Harsat.
Thank you, Professor Juha.
Thank you. Bye-bye. Until next time.
Bye.
Bye-bye.
Bye-bye, Hirotoshi.
Bye.
Very nice to meet you.
Yes.
Bye-bye.
Yeah.
John?
Yes, hi, Warlocks.
So the Zoom have the maximum, like, it have the limitation for the accept peoples, right?
Yeah, it's 100 usually. That's what it is. 100. We've reached the limit. If there are more, they can't get in. And there's really no advantage because you can get an account with 500 people where 100 people can come in and there's 400 people that can stay in the waiting room and they can text and they can watch. But there's really no advantage because you can text and watch on YouTube. You know what I mean? You don't need to be in this platform. You just go on YouTube, watch it. And if you have a question, you just text it on YouTube. We haven't really advanced to the point of, having someone watch YouTube because we haven't really had many questions on YouTube. But I think people, once they get to know the technology and are comfortable with it, do you know what I mean? It takes a while to get comfortable with this technology, I think. Do you feel comfortable with it, Warlocks?
Yeah, it's fun. I mean, so it's just like a game. So I just keep accepting people until it reached 100, and then I cannot accept them anymore. So I mean, if people who want to join the webinar and then my name not got accepted, maybe I will feel sad a little bit. So just ask. But
well, hopefully it'll get to a point where people have to bribe us to come in.
No, but normally they will you you join some concert. Okay, maybe you can watch on the TV, but it's more memorable if you are in the movement. You're just kidding, though.
Yeah, well, you have to get there early. The first 100, and then you cut off. No, we'll explore this. There's something called a breakout room which is available on some versions of Zoom, where if you have a discussion, you can make another room for them to go in. Like right now, if a couple of neurosurgeons start discussing something, and they wanted to get together with the other people discussing it, you make a room. Do you know what I mean? It's called a breakout room.
Okay.
I don't know if we have use for that initially, but I think it's a learning process. We learn this platform, we use it, we manipulate it. And you know what? You know what, Warlocks? We make technology serve us.
Okay.
We don't serve technology. It serves us.
Okay.
So how was your night? This is your night now. Your night now, right?
Oh yeah, it's 8 o'clock now.
Yeah, you work today?
Yes, I work every day actually.
Oh, okay. Okay.
No, I mean now I'm fellowship, so work and study same time. So yeah.
Okay. Yeah, Vlad came. Let's see who else.
Oh, forget to ask. So what is the final for the IMC session topics?
Yeah, it's I haven't heard. Have you been communicating directly with Lewis about? Because I wrote to him and asked him if they needed changes, but I haven't heard back. Are you hearing from him something? No, don't worry about it. Don't worry about it. Because Lewis has my WhatsApp. He communicates with me pretty good. So I'll confirm with him that everything's okay.
I have already changed hospital names.
You know, I made a mistake. I confused a couple of conferences this weekend. Spanish.
Yeah.
I thought there was one Spanish, but there were two Spanish conferences, and I just figured it out. But we're okay. We're okay for tomorrow. There's one on. Oh, have you? Oh, I'd like to announce this for the crowd.
What?
Warlocks, can I have a drum roll? There you go. There you go. There you go. Okay, we have this conference. Can you see this okay?
Yes.
This is a conference in Spanish on Parkinsonism on tomorrow at 10 o'clock Ecuador time. Let me see, the other conference we have is a conference on peripheral nerve injury, with it's going to be a series, and it's just starting tomorrow. Okay, let me open that up. Just give me a second. Are you interested in peripheral nerve, Borlix? Does that interest you at all? Not really.
Yes, but we do not really have lots of cases here. And it's still countries of trauma and vascular case. So yeah, but it's mandatory though. I mean, every neurosurgery you have.
You got to take a rotation, right? You got to take a month or so.
Yes.
Oh, here it is. Okay. Okay, hold on. Okay, let me get it up here so people can see it, and I'll put the link in the chat. Okay, there is. You can see that, Warlocks?
Yes. So it's the serious peripheral nerve injury with Dr. Michael Maloney tomorrow, right?
For Maloney, right? Yeah, I'll put for the panelists, you're welcome to come to this tomorrow, 6 o'clock Rome time, noon. Let me put the link. Let me put the link in the chat.
I think
yeah, I'll get the link. It's all on my Facebook account, but if you don't have it, let me get it for you.
So like in Europe and in US now, like most of you are locked down.
Well, you know what, Warlocks, I'm going to show you the Chinese website that we were on. Okay, there's a Chinese, because that was televised in Chinese. You see it, Warlocks?
Yes, I saw that.
Yeah. Oh, you saw it? Oh, you saw it already? Okay. Okay, let me see if I can get the, let me see if I can put the link in the chat there.
Vienes que nos hablan ahora. Todo sopla, si no quieres.
Yo no quiero que me esté ahí.
Que no quiero que qué.
Okay, there it is. Let me get the link. Just give me a second. Okay, I got it. Okay. I'm putting the link in the panel for everyone to come to this conference of let me see, of peripheral nerve injury. Okay, it's a series. It'll go probably between 6 to 10 weeks every Saturday at the same time, and you have to register. The link is to register is in the chat box, so that you get the link for all of them. So please register if you want to see it. And will you have a chance to go, Warlocks? Or are you going to be busy?
Tomorrow?
Are you going to go to it, you think, tomorrow? Oh, you're going to be around tomorrow?
Yeah, if I do not have anything to do besides read a book, I will join.
Yeah, okay, I'll let you know. Okay, it's at your time. It would be yeah, almost like 9 o'clock.
What language?
Yeah, well, Marco's in English.
Oh,
he's in English. Yeah, no, he's in English, but the other one's in Spanish. But I don't think you want to come to that one. You can come. You're welcome to come.
No, I did not took a Spanish class yet, so I had to take it first.
Well, I found one thing you can't do. Oh my God, you don't speak Spanish.
No, you can't.
How many languages? You speak Thai and English, obviously. When you grew up, were you speaking English most of the time, or were you speaking Thai?
No. My mom left me in the British consulate, because British consulate they teach like English. So yeah, I grew up there.
Oh, so you grew up speaking English?
Yes, but I do not have British accent at all.
Oh, really? You have a Brooklyn accent.
A Thai accent. Okay. So I think we have to close the webinar because other people still hang around.
Yeah. Does anybody want to meet us or talk to us? You may not think I'm interested, but how about Warlocks?
No, I hate that.
Anybody want to meet Warlocks? He's a neurosurgeon from Thailand. Not meet, but I mean professionally.
Just close the webinar.
That's what I'm talking about, professionally now.
Yeah. Okay, John, see you tomorrow then.
Yeah, I guess we got to go. Okay, Warlocks, thanks a lot. And we'll and any questions about Lewis, just let me know.
Okay, but he not reply me, so I guess that both of them will satisfy with that topics in which I understand Louis, because that topic is cover all everything that Juha mentioned though.
Yeah, okay, we'll keep in touch.
Oh, don't forget, we have IP Monday.
Yeah, neurosurgery, neuroanatomy, right?
I just remind you, that's all.
Yeah, did you make that? You made that banner already, right? Yeah, you made it.
I make that in advance just in case I'm too busy to make that. So
Yeah, sometimes I get confused, but
sometimes I'm gonna remind you.
yeah, it's age. Okay.
Okay.
Okay, Bollocks. Take it easy now. Bye-bye.